Welcome, nursing warriors. Your journey to NCLEX mastery begins here. Today's video focuses on the pharmacology of the reproductive and maternity system, a crucial and frequently tested area. We will go through 15 high-yield NCLEX-style questions, covering key medications used in fertility, pregnancy complications, labor, postpartum care, and emergency contraception. Each question includes detailed explanations to boost your clinical thinking and confidence. And remember, we post brand new exam-focused videos every single day, so be sure to follow us and tune in daily to stay ahead in your NCLEX prep. Let us jump right into today's most important pharmacology questions. Right before we get into the question, let me ask you this. Is your NCLEX prep complete? If not, the complete NCLEX review course gives you 100 hours of animated video lectures, 500 hours of lecture content, 5,000 high-yield questions, 500 NGN case studies, and 15 mock exams, all with a year-long ebook. Save 70% today, but the deal won't last. Click the description link to enroll and start strong. Let us challenge our understanding with question number 1. A 30-year-old primigravida at 41 weeks of gestation is admitted to the labor and delivery unit for induction of labor. After artificial rupture of membranes and 24 hours of spontaneous labor, cervical change remains minimal despite adequate contractions. The labor progress has plateaued with no descent or dilation over the past 4 hours. Which medication should the nurse anticipate administering to augment uterine contractions and facilitate labor progression? Next, let us consider the available treatment options. Option A, dinoprostone. Option B, meperidine. Option C, oxytocin. Option D, nifedipine. Now, let us identify the correct therapy. The correct option is option C, oxytocin. Let us proceed to understand why this teaching point is paramount and why the other answers miss the mark. Oxytocin is a synthetic form of the endogenous hormone that binds to oxytocin receptors on the myometrium, increasing intracellular calcium and promoting coordinated, forceful uterine contractions. In cases of labor dystocia with adequate cervical ripening but poor contractility or lack of progress, careful titration of oxytocin infusion can augment contraction frequency, duration, and strength, promoting cervical dilation and fetal descent. Continuous monitoring of maternal vital signs, contraction pattern including frequency, duration, and intensity, and fetal heart rate is essential to detect tachysystole and signs of fetal distress. Dinoprostone is a prostaglandin E2 analog used primarily for cervical ripening and induction of labor. While it ripens the cervix, it does not directly enhance the strength or frequency of uterine contractions in established labor dystocia. Meperidine is an opioid analgesic used for pain management during labor. Although it provides maternal comfort, it does not address the underlying issue of ineffective uterine contractions and may mask true labor progress or contribute to uterine inertia. Nifedipine is a calcium channel blocker used as a tocolytic agent to inhibit preterm uterine contractions. In the setting of labor dystocia, nifedipine would further suppress contractility, exacerbating an already non-progressing labor. Remember that labor dystocia is often multifactorial, involving malpresentation, cephalopelvic disproportion, or uterine dysfunction. Always assess fetal position pelvic adequacy and contraction pattern before escalating to pharmacologic augmentation. Initiate oxytocin at a low-dose infusion, for example 2 milliunits per minute, and titrate upward every 30 to 60 minutes, observing for hyperstimulation such as more than 5 contractions in 10 minutes and uteroplacental insufficiency. When administering oxytocin, maintain the client in a semi-Fowler's or side-lying position to optimize uterine perfusion and minimize vena cava compression. Evaluate fluid balance closely. Adequate maternal hydration is necessary before starting oxytocin, since hypovolemia can potentiate hypotension or uterine hyperactivity. Always have tocolytic agents, for example, terbutaline, readily available to manage uterine tachysystole or signs of fetal compromise. Here's another scenario that might look familiar on exam day. Question number 2. A 22-year-old client presents to the family planning clinic reporting unprotected intercourse 60 hours ago and is concerned about preventing pregnancy. Which agent should the nurse expect the provider to recommend for emergency contraception? Next, review the answer choices. Option A, raloxifene. Option B, levonorgestrel. Option C, mifepristone. Option D, depot-medroxyprogesterone acetate. The correct option is option B, which is levonorgestrel. Now we will illustrate why this concept is crucial and why the other choices do not apply. Option B, levonorgestrel, is a progestin-only emergency contraceptive that is most effective when taken within 72 hours after unprotected intercourse, but it may still offer some benefit up to 120 hours later. Its primary mechanism of action is delaying or inhibiting ovulation by suppressing the luteinizing hormone surge, which prevents the release of an egg. It does not terminate an existing pregnancy or affect implantation. Levonorgestrel is well tolerated, although it may cause side effects like nausea, fatigue, dizziness, breast tenderness, or irregular bleeding. Clients should be informed to take the dose as soon as possible, and if vomiting occurs within 2 hours, a second dose may be needed. Option: Raloxifene is a selective estrogen receptor modulator used to treat and prevent osteoporosis and reduce the risk of breast cancer in postmenopausal women. It has no effect on ovulation and no role in emergency contraception, making it an inappropriate choice in this scenario. Option C, mifepristone, is an antiprogestin used to terminate an established intrauterine pregnancy by blocking progesterone receptors and causing the uterine lining to break down. It does not delay ovulation and is not approved for use as emergency contraception in the setting of recent unprotected intercourse. Option D, depot-medroxyprogesterone acetate is a long-acting injectable contraceptive that provides pregnancy prevention for approximately 3 months. However, it is not suitable for emergency contraception because it does not act quickly enough to suppress ovulation after a single dose. As an additional clinical pearl, emergency intrauterine device placement with a copper intrauterine device within 5 days of unprotected intercourse is the most effective method of emergency contraception and can serve as a long-term option. Always counsel clients on the time sensitivity of emergency contraceptives and encourage them to consider consistent, long-term contraceptive methods to avoid future unplanned pregnancies. Here comes a clinical scenario that truly tests your understanding of reproductive pharmacology, with question number 3. A 28-year-old client presents to the Women's Health Clinic with complaints of lower abdominal cramping and spotting. Transvaginal ultrasound reveals a suspected tubal ectopic pregnancy measuring 2.5 centimeters, no fetal cardiac activity, and a serum human chorionic gonadotropin level of 3,200 milli-international units per milliliter. The client is hemodynamically stable, has no contraindications to chemotherapy, and desires to preserve fertility. Which medication should the nurse anticipate administering for medical management? Let us now take a look at the options. Option A, misoprostol. Option B, clomiphene citrate. Option C, methotrexate. Option D, Rho-D-immune globulin. The correct option is option C, which is methotrexate. Now, let us break this down and explore why this is the most appropriate choice. Methotrexate is a folic acid antagonist that interferes with deoxyribonucleic acid synthesis and cellular replication in rapidly dividing trophoblastic cells. It is considered the gold standard for non-surgical management of a hemodynamically stable ectopic pregnancy, particularly when the ectopic mass is smaller than 3.5 centimeters. Fetal cardiac activity is absent, and the human chorionic gonadotropin level is below 5,000 milli-international units per milliliter, all of which apply to this client. Methotrexate may be given intramuscularly or directly into the ectopic mass depending on clinical protocols. It allows the pregnancy to resolve without damaging the fallopian tube, thereby preserving future fertility. The client must be closely monitored with serial human chorionic gonadotropin measurements until the hormone becomes undetectable to confirm resolution. It is crucial to advise against folic acid supplementation and alcohol use during therapy because these can increase the risk of methotrexate toxicity. Now, examining the other choices. Option: misoprostol is a prostaglandin E1 analog used for cervical ripening and intrauterine pregnancy termination, but is not effective against trophoblastic tissue in an ectopic site and is therefore not used in this setting. Option B, clomiphene citrate, is used to stimulate ovulation in individuals experiencing infertility and does not have any role in treating ectopic pregnancy. In fact, using it during an ongoing pregnancy is contraindicated. Option D, Rho-D-immune globulin, is administered to rhesus-negative individuals after events that could cause fetal-maternal blood mixing to prevent rhesus sensitization, but it does not treat ectopic pregnancy and would only be an adjunct consideration if the client is rhesus negative. As an essential clinical takeaway, methotrexate should only be used in candidates who meet strict criteria: no signs of tubal rupture, hemodynamic stability, absence of fetal cardiac activity, and acceptable human chorionic gonadotropin levels. Monitor liver enzymes, renal function, and complete blood count before administration, and instruct the client to avoid pregnancy for at least 3 months due to the teratogenic effects of methotrexate. Always ensure that emergency surgical resources are available in case the client develops signs of tubal rupture, such as sudden severe abdominal pain or hemodynamic instability. Let us tackle another high-yield scenario with question number 4. A 68-year-old male client diagnosed with benign prostatic hyperplasia is started on Tamsulosin. During discharge teaching, which instruction should the nurse emphasize to the client? Now, here are the available options. Option A. Take the first dose at bedtime with a snack. Option B. Change positions slowly when standing or sitting. Option C. Monitor for dark yellow or orange urine. Option D. Avoid consuming dairy products within 2 hours of the dose. The correct option is option B, which is change positions slowly when standing or sitting. So, let us unpack why this is the most important teaching point and clear up any confusion around the other choices. Tamsulosin works by relaxing the smooth muscles in the bladder, neck, and prostate, which helps improve urine flow in clients with benign prostatic hyperplasia. However, it also causes peripheral blood vessels to relax, leading to a drop in blood pressure, especially when standing up too quickly. This effect, known as orthostatic hypotension, can result in dizziness or fainting, particularly during the first few doses. That is why teaching the client to rise slowly from lying or sitting positions is essential for safety. Moving on to the other options. Option L. Take the first dose at bedtime with a snack might seem like a good idea, because taking the first dose at bedtime can lessen dizziness, but it does not address the ongoing risk of blood pressure drops during daily activities. Emphasizing position changes is far more impactful for long-term safety. Option C, monitor for dark yellow or orange urine, is not appropriate here, since Tamsulosin does not typically cause any change in urine color. That kind of side effect is more associated with drugs like phenazopyridine or rifampin. Teaching this would only create confusion. Option D, avoid consuming dairy products within 2 hours of the dose is another incorrect teaching point. Unlike some antibiotics that interact with calcium, Tamsulosin has no significant food or dairy restrictions, so there is no need to limit milk or other calcium-rich products around dosing time. As a clinical tip, remind clients about the first dose phenomenon and encourage them to take their first dose at bedtime. But more importantly, emphasize changing positions slowly every time. They should also be told to report any dizziness, lightheadedness, or near fainting spells immediately. And if they are scheduled for cataract surgery, do not forget, Tamsulosin can lead to a condition called intraoperative floppy iris syndrome, so the eye surgeon needs to know about current or past use. Always advise clients to maintain hydration and avoid stopping the medication suddenly, as this could worsen urinary retention or symptoms of benign prostatic hyperplasia. Get ready for another critical maternity care question with question number 5. A 32-year-old primigravida at 32 weeks of gestation with severe preeclampsia is receiving a continuous magnesium sulfate infusion at a secondary care facility. The infusion was initiated to prevent eclamptic seizures. Which parameter should the nurse prioritize when monitoring this client during the magnesium sulfate infusion? Now let us take a look at the answer options. Option A, heart rate and rhythm. Option B, serum creatinine level. Option C, visual acuity assessment. Option D, auscultation of bowel sounds. The correct option is option A, which is heart rate and rhythm. Now let us dive into why this monitoring parameter is the top priority during magnesium sulfate therapy. Magnesium sulfate is a central nervous system depressant and smooth muscle relaxant that is commonly used to prevent eclamptic seizures in clients with severe preeclampsia. However, in higher concentrations, it can depress cardiac conduction and lead to serious complications such as bradycardia, atrioventricular block, and even cardiac arrest. That is why continuous monitoring of heart rate and rhythm is essential, either through telemetry or frequent manual auscultation, to detect any signs of magnesium-induced cardiotoxicity early. If a client begins to show signs like prolonged P-wave to R-wave interval, sudden bradycardia, or new conduction abnormalities, the infusion must be stopped immediately, and serum magnesium levels should be evaluated without delay. Now let us look at why the other options are incorrect. Option B, serum creatinine level is not the best indicator for acute magnesium toxicity. Although poor renal function can reduce magnesium excretion and increase toxicity risk, creatinine levels change slowly and do not reflect real-time magnesium accumulation. Instead, nurses should prioritize hourly urine output to ensure the kidneys are clearing the drug effectively. Option C, visual acuity assessment might seem relevant because blurred vision or scotomata are often reported in preeclampsia. However, these symptoms are related to the disease itself, not directly to magnesium sulfate toxicity, and visual checks will not help identify cardiac or respiratory depression caused by the medication. Option D, auscultation of bowel sounds is not a reliable or priority assessment during magnesium infusion. While magnesium can cause muscle relaxation, it does not typically affect gastrointestinal motility, to the point that bowel sounds would serve as an indicator of toxicity. For your clinical toolkit, remember to assess deep tendon reflexes every 30 minutes since diminished or absent reflexes often appear before respiratory or cardiac depression in magnesium toxicity. Maintain urinary output above 30 milliliters per hour to help prevent magnesium accumulation. Always keep calcium gluconate at the bedside as the antidote. It should be administered intravenously over 3 to 5 minutes if signs of toxicity occur. Monitor respiratory rate closely, and be ready to intervene if it falls below 12 breaths per minute. Also, educate the client and family to immediately report chest discomfort, palpitations, or the sensation of skipped heartbeats, as these may indicate early signs of magnesium-induced cardiac issues. Here comes a question focused on immediate postpartum care. Question number 6. A 34-year-old multi-parous client on the postpartum unit is noted to have excessive lochial flow, boggy fundal tone, and tachycardia 2 hours after vaginal delivery of a healthy infant. The primary healthcare provider orders methylorgonavine, which clinical finding indicates the medication is producing the desired therapeutic effect. Now, let us look at the answer choices. Option A, flaccid relaxed uterine fundus. Option B, onset of bradycardia and hypotension. Option C, widening of peripheral venous pulse pressure. Option D, reduction in postpartum vaginal bleeding. The correct option is option D, which is reduction in postpartum vaginal bleeding. Now, let us explore what makes this the correct choice and why the other options do not apply. Methylorgonavine is an ergot alkaloid that stimulates alpha-adrenergic receptors in uterine smooth muscle, causing powerful sustained uterine contractions and vasoconstriction of the uterine blood vessels. The goal of this medication is to treat postpartum hemorrhage by improving myometrial tone and minimizing blood loss. When the uterus contracts effectively, it compresses the open blood vessels at the placental site, reducing lochial flow. Clinically, this therapeutic effect is observed through a reduction in vaginal bleeding, fewer saturated perineal pads, and less visible blood on the bed linens. Now consider why the other responses are incorrect. Option: a flaccid, relaxed uterine fundus is actually a sign of uterine atony, which is the very condition methylorgonavine is intended to correct. If the uterus remains soft or boggy, it means the medication is not working effectively. Option B, onset of bradycardia and hypotension is also not a desired outcome. Methylorgonavine may lead to vasoconstriction and sometimes reflex bradycardia, but hypotension is not expected. In fact, the medication more commonly causes elevated blood pressure, and hypotension would be more concerning than reassuring. Option C, widening of peripheral venous pulse pressure, is unrelated to uterine tone or bleeding control and would not be a useful or reliable indicator of methylorgonavine's effectiveness. This change in pulse pressure could be related to multiple systemic conditions, but it does not reflect uterine perfusion or contraction. From a clinical standpoint, always verify baseline blood pressure before administering methylorgonavine, as it is contraindicated in clients with hypertension, preeclampsia, or vascular disease due to its strong vasoconstrictive action. The medication is typically given intramuscularly or orally and should not be given intravenously unless in an emergency setting with close cardiovascular monitoring. Combine uterine massage with methyl-ergonovine to enhance its effect, and check the client's blood pressure every 15 minutes for at least 1 hour after dosing. Educate the client that mild cramping or elevated blood pressure is expected, but symptoms like a severe headache, chest pain, or visual changes should be reported immediately, as they may signal serious complications such as hypertensive crisis or coronary vasospasm. Wait a moment before we continue. This could change your entire NCLEX prep. Our complete NCLEX review course includes 100 hours of animated lectures, 500 hours of deep dive teaching, 5,000 powerful practice questions, 500 NGN-style case studies, and 15 full-length exam simulations. You'll also receive a full-access NCLEX ebook for 12 months. The course is now 70% off, but not for long. Tap the link in the description and get started right now. Let's keep going with another confidence-building question about rhesus incompatibility and pregnancy with question number 7. A 24-year-old rhesus-negative primigravida is scheduled for routine prenatal care. The nurse discusses the prophylactic administration of Rho-D immune globulin to prevent isoimmunization. At which intervals should the nurse explain that Rho-D immune globulin is indicated? Now, let us look at the options. Option A, 20 weeks of pregnancy and within 72 hours of delivery. Option B, 28 weeks of pregnancy and within 72 hours of delivery. Option C, only within 72 hours after a spontaneous abortion at 10 weeks. Option D, 30 weeks of pregnancy and within 48 hours of delivery. The correct option is option B, which is 28 weeks of pregnancy and within 72 hours of delivery. Now, let us understand exactly why this timing is so important and what makes the other options incorrect. Rho-D immune globulin is a blood product used to prevent rhesus sensitization in rhesus-negative individuals who may be carrying a rhesus-positive fetus. When administered at 28 weeks of gestation, it ensures circulating anti-D antibodies are present during the critical third trimester when the risk of fetal-maternal blood mixing increases. A second dose is given within 72 hours after delivery, if the newborn is rhesus-positive, to neutralize any fetal red blood cells that may have entered the maternal circulation. This prevents the mother's immune system from forming permanent antibodies against rhesus-positive blood, which could harm future pregnancies. Now, let us break down why the other choices are not appropriate. Option: a 20 weeks of pregnancy and within 72 hours of delivery is too early for the first dose because anti-D levels could decline before the higher-risk third trimester, leaving the client unprotected. Option C: only within 72 hours after a spontaneous abortion at 10 weeks is also incorrect, because while some protocols recommend anti-D after pregnancy loss beyond 12 weeks, routine administration at 10 weeks is not standard unless there is evidence of fetal maternal hemorrhage. Giving Rho-D immune globulin only in this context misses its broader preventive role during an ongoing pregnancy. Option D, 30 weeks of pregnancy and within 48 hours of delivery is incorrect, because delaying until 30 weeks misses the ideal window for early third trimester protection, and giving the postpartum dose within only 48 hours instead of 72 may not allow enough time for antibody binding and effective prevention of sensitization. As a clinical pearl, Rho-D immune globulin should also be administered after procedures like amniocentesis, chorionic villus sampling, or any abdominal trauma during pregnancy, particularly after 20 weeks. Always verify the rhesus status of both parents if possible, and if the infant's rhesus status is unknown at delivery, give the dose and discontinue later if the infant is confirmed rhesus negative. For pregnancy loss or termination after 13 weeks, ensure administration of Rho-D immune globulin within 72 hours to maintain protective coverage and reduce the risk of maternal sensitization in future pregnancies. Let us shift our focus to postpartum infections with question number 8. A 31-year-old postpartum client on day 10 presents with unilateral breast erythema, tenderness, and low-grade fever. She reports difficulty fully emptying the affected breast while breastfeeding. Physical assessment reveals a firm, warm, indurated area without fluctuance. The primary healthcare provider orders antibiotic therapy. Which agent should the nurse anticipate administering to treat her mastitis? Now, here are the available options. Option A, ketoconazole. Option B, acyclovir. Option C, cephalexin. Option D, metronidazole. The correct option is option C, which is cephalexin. Now let us explore why this is the most appropriate treatment and why the other options fall short. Cephalexin is a first-generation cephalosporin that has excellent coverage against methicillin-sensitive Staphylococcus aureus and Streptococcus, which are the most common organisms responsible for lactational mastitis. It effectively penetrates breast tissue, is safe for breastfeeding, and typically requires a 10 to 14-day course. Cephalexin works by inhibiting bacterial cell wall synthesis, which leads to rapid bacterial destruction, decreased inflammation, and pain relief. Importantly, it also helps prevent the development of a breast abscess, allowing the client to continue breastfeeding from the affected side without interruption. Now, turning to the incorrect choices, option A, ketoconazole, is an antifungal medication used for systemic fungal infections, such as candidiasis. It has no efficacy against the typical bacterial causes of mastitis, and more critically, is contraindicated in breastfeeding due to its potential for hepatotoxicity and excretion into breast milk. Option B. Acyclovir is an antiviral used for herpes simplex virus infections. Mastitis, particularly in lactating women, is bacterial in origin, primarily involving gram-positive cocci, not viral. Prescribing acyclovir would delay appropriate treatment and allow the infection to worsen. Option D, metronidazole, is used to treat anaerobic bacterial infections and some protozoal conditions. Since mastitis is most often caused by aerobic bacteria, like Staphylococcus aureus and Streptococcus, metronidazole lacks the coverage needed and is not recommended as monotherapy in this situation. From a clinical standpoint, always advise clients to continue breastfeeding or expressing milk every 2 to 3 hours to promote drainage and avoid milk stasis, which can worsen the infection. Teach proper latch techniques and suggest alternating breastfeeding positions to ensure all quadrants of the breast are drained effectively. Warm compresses applied before feeding or pumping can ease discomfort and promote better milk flow. Be on the lookout for warning signs of abscess formation, such as a fluctuant mass, worsening pain, or high-grade fever. These require prompt intervention like ultrasound-guided aspiration or surgical drainage. Also remind clients to rest, stay well hydrated, and use non-steroidal anti-inflammatory drugs for symptom relief. Time to level up again. Here comes question number 9. A 29-year-old prima gravida is receiving a continuous terbutaline infusion to prevent preterm labor. Which maternal assessment finding indicates that it is safe to continue the infusion? Here are the options to evaluate. Option A, blood glucose 106 milligrams per deciliter. Option B, respiratory rate 24 breaths per minute. Option C, oxygen saturation 90% on room air. Option D, serum potassium 3.0 milliequivalents per liter. The correct option is option A, which is blood glucose 106 milligrams per deciliter. Now, let us break down why this finding supports continued therapy and why the others indicate potential harm. Terbutaline is a beta-2 adrenergic agonist used to relax uterine smooth muscle and delay preterm contractions. However, it has systemic effects, including raising blood glucose levels by stimulating glycogen breakdown and gluconeogenesis. A blood glucose reading of 106 milligrams per deciliter falls within the normal range of 70 to 110 milligrams per deciliter, showing that the client is tolerating the medication without significant metabolic stress, and thus the infusion can be safely continued. On the other hand, option B, respiratory rate 24 breaths per minute, may seem borderline normal, but it can be an early sign of pulmonary edema, especially in a client receiving terbutaline. Terbutaline increases capillary permeability and can lead to fluid accumulation in the lungs. A rising respiratory rate could be the first indicator of impaired oxygenation, and this finding should prompt immediate reassessment. Option C, oxygen saturation 90% on room air is clearly abnormal. An oxygen saturation below 92% is a red flag suggesting impaired gas exchange, potentially due to terbutaline-induced pulmonary edema. This level warrants stopping the infusion immediately, providing oxygen, and initiating a full respiratory workup. Option D, serum potassium 3.0 milliequivalents per liter reflects significant hypokalemia. Terbutaline promotes the intracellular shift of potassium, reducing serum levels and increasing the risk of cardiac arrhythmias. Before continuing the infusion, The potassium deficit must be corrected to avoid serious cardiac complications. Clinically, when using terbutaline, it is critical to monitor not only uterine activity, but also respiratory status, oxygen saturation, and electrolyte levels. Always assess for signs of pulmonary edema, such as increasing respiratory rate, crackles on auscultation, or declining oxygen levels. Monitor deep tendon reflexes, even though neuromuscular toxicity is more commonly associated with magnesium sulfate, and track intake and output closely, since fluid shifts and hypotension can worsen terbutaline side effects. Also, ensure that the client is on continuous cardiac monitoring, especially when there is any evidence of tachycardia or low potassium levels. Remember, terbutaline therapy should be limited to no more than 48 to 72 hours due to the increased risk of serious cardiovascular and metabolic adverse effects with prolonged use. Stay focused. Here's your next high-yield checkpoint. Question number 10. A 24-year-old primigravida at 32 weeks of gestation presents with preterm labor and premature rupture of membranes. The primary healthcare provider prescribes Betamethasone. Which outcome indicates that the medication is achieving its intended fetal effect? Now, review the options. Option A, increase in maternal blood glucose levels. Option B, decrease in maternal uterine contractility. Option C, maternal blood pressure remains stable. Option D, fetal breathing movements observed on ultrasound. The correct option is option D, which is fetal breathing movements observed on ultrasound. Now, let us explore the reasoning behind this answer and understand why it reflects the drug's intended action. Betamethasone is a corticosteroid administered to accelerate fetal lung maturation by promoting the production of surfactant in type 2 pneumocytes. Surfactant is essential for reducing surface tension within the alveoli and preventing lung collapse after birth. Within 24 to 48 hours after the first dose, one of the earliest signs of improved fetal lung function is the appearance of rhythmic breathing movements observed via ultrasound. These movements are a direct indication that surfactant synthesis is underway and the fetus is preparing for extrauterine life. Now, turning to the incorrect responses. Option: an increase in maternal blood glucose levels is a known side effect of corticosteroids like betamethasone, especially in clients with or at risk for gestational diabetes. However, this maternal response is not a sign of the drug's efficacy on fetal lung development and is instead considered an adverse effect that must be monitored. Option B, decrease in maternal uterine contractility is inaccurate because betamethasone does not have significant tocolytic properties. If suppression of contractions is needed, medications like Nifedipine or indomethacin are typically used alongside betamethasone to delay delivery long enough for the steroid to work. Option C, maternal blood pressure remains stable may be a desirable condition, but it does not relate to the goal of enhancing fetal lung maturity. In fact, corticosteroids can transiently elevate blood pressure, particularly in sensitive individuals. Clinically, the standard regimen is 2 doses of 12 milligrams of betamethasone given intramuscularly 24 hours apart. The medication reaches peak effect within 48 hours of the first dose, so tocolytic therapy is often used to delay labor and allow time for lung development. Monitor maternal blood glucose every 6 to 8 hours during therapy, especially in clients with diabetes, and be cautious about repeated courses of corticosteroids, as excessive dosing has been associated with fetal growth restriction. A single rescue dose may be considered if the risk of preterm delivery persists more than 14 days after the initial course. Overall, antenatal corticosteroid therapy significantly reduces the risk of neonatal respiratory distress syndrome, intraventricular hemorrhage, and necrotizing enterocolitis, making it a cornerstone of preterm labor management. This next question is a game changer. Question number 11. A 28-year-old client at 26 weeks of gestation is admitted with regular uterine contractions. The primary healthcare provider orders Nifedipine for tocolysis. Which factor should the nurse assess before administering Nifedipine? Here are the options to consider. Option A, baseline maternal blood pressure. Option B, serum magnesium level. Option C, fetal heart rate variability. Option D, maternal platelet count. The correct option is Option A, which is baseline maternal blood pressure. Now, let us discuss why this is the most essential assessment and clarify why the others are not required before administering Nifedipine. Nifedipine is a calcium channel blocker used off-label for tocolysis. It works by inhibiting calcium influx into myometrial cells, which decreases uterine contractions. However, since it also causes systemic vasodilation, one of the most significant side effects is maternal hypotension. Checking the baseline blood pressure is critical to ensure the client can tolerate the medication without risking decreased utero-placental perfusion or dizziness. Monitoring for orthostatic changes is also wise, especially with the initial dose. Now, regarding the other options. Option B, serum magnesium level, is not relevant in this scenario unless magnesium sulfate is also being administered. Magnesium levels are primarily monitored when magnesium sulfate is used for seizure prophylaxis or tocolysis, not with Nifedipine. Option C, fetal heart rate variability, is important in overall fetal surveillance, especially in the context of preterm labor. However, it does not influence whether Nifedipine should be administered, as the drug has minimal direct effect on fetal heart rhythm and variability. Option D, maternal platelet count, is significant when considering medications like magnesium sulfate, which can affect platelet levels in preeclampsia, or Betamethasone, which may impair platelet function. But for Nifedipine, platelet count does not affect drug safety unless the client is also on anticoagulants or has a bleeding disorder. From a clinical perspective, Nifedipine is usually started with an initial oral dose of 20 milligrams, followed by 10 to 20 milligrams every 4 to 6 hours as needed. It is essential to monitor blood pressure and heart rate after each dose and to position the client in the left lateral or supine position to reduce the risk of orthostatic hypotension. Never administer Nifedipine concurrently with magnesium sulfate due to their additive hypotensive effects. Always separate the doses by at least 2 hours. Also, assess for side effects such as headache, facial flushing, and peripheral edema, all related to its vasodilatory properties. Nifedipine is often used to delay labor for up to 48 hours, giving enough time for corticosteroids like Betamethasone to promote fetal lung maturity and possibly for safe transfer to a higher-level facility if needed. Let us now explore a critical safety scenario involving seizure prophylaxis in preeclampsia with question 12. A 32-year-old primigravida at 34 weeks of gestation with severe preeclampsia is receiving magnesium sulfate for seizure prophylaxis. Which maternal finding would prompt the nurse to stop the infusion immediately? Here are the options. Option A, heart rate of 78 beats per minute. Option B, deep tendon reflexes graded at 2+. Option C, serum creatinine 0.8 milligrams per deciliter. Option D, respiratory rate of 10 breaths per minute. The correct option is Option D, which is respiratory rate of 10 breaths per minute. Now, let us break down exactly why this finding demands urgent intervention. Magnesium sulfate acts as a central nervous system depressant to prevent eclamptic seizures, but in excessive amounts, it can suppress respiratory drive. A respiratory rate below 12 breaths per minute is one of the earliest signs of magnesium toxicity, and a rate of 10 breaths per minute indicates the onset of respiratory compromise. In this situation, the infusion must be stopped immediately, and calcium gluconate should be administered, typically 1 gram intravenously over 3 to 5 minutes, to reverse the effects and prevent respiratory arrest. Now examining the incorrect choices. Option: a heart rate of 78 beats per minute is well within the normal adult range of 60 to 100 beats per minute. While magnesium can cause bradycardia and severe toxicity, a heart rate of 78 is stable and does not indicate any need to stop the medication. Option B, deep tendon reflexes graded at 2+ are considered normal. The concern with magnesium sulfate therapy is the loss or weakening of these reflexes, typically graded as 0 or 1+, since that often precedes respiratory depression. A reflex rating of 2+ suggests that magnesium levels are not yet reaching toxic thresholds. Option C, serum creatinine 0.8 milligrams per deciliter reflects normal renal function, which is important because magnesium is excreted primarily through the kidneys. Adequate renal clearance means the risk of accumulation is lower, so this lab value actually supports the continued safe use of the infusion. Clinically, it is essential to monitor respiratory rate, oxygen saturation, and work of breathing closely in any client on magnesium sulfate. Watch for signs such as decreased effort, use of accessory muscles, or cyanosis. Assess deep tendon reflexes every 15 to 30 minutes, because changes in neuromuscular function often appear before respiratory depression. Urinary output should be maintained above 30 milliliters per hour, to ensure magnesium is being cleared appropriately. Always have calcium gluconate readily available at the bedside for immediate administration if toxicity occurs. Educate clients that a sensation of flushing or warmth after starting the infusion is common and not harmful. But they must report any breathing difficulty or tightness in the chest right away, as those are signs of emerging toxicity. Hold on just a sec. Let's talk strategy. The complete NCLEX Review online course is your fast-track prep kit. 100 animated hours, 500 hours of lectures, 5,000 questions, 500 NGN-style case studies, and 15 exam simulations. All this plus a year-long NCLEX ebook. Act fast, it's now 70% off for a limited time. Visit our site using the link in the description and start today. Let's see if you can apply what you've learned with question number 13. A 27-year-old client with polycystic ovary syndrome is planning to conceive and is started on Clomiphene citrate. Which factor should the nurse include when teaching this client about Clomiphene therapy? Here are the options to consider. Option A. Take the medication continuously until pregnancy is confirmed. Option B. Expect potential weight gain due to fluid retention. Option C. Discontinue use if vaginal bleeding occurs concurrently. Option D. Undergo a transvaginal ultrasound to monitor follicular development. The correct option is option D, which is undergo a transvaginal ultrasound to monitor follicular development. Now, we will break down why this particular point is essential and determine what disqualifies the other options. Clomiphene citrate is a selective estrogen receptor modulator that works by blocking estrogen receptors in the hypothalamus. This leads to an increase in gonadotropin-releasing hormone secretion, which in turn stimulates the anterior pituitary to release follicle-stimulating hormone, promoting ovarian follicular development. Transvaginal ultrasound is the standard method for monitoring follicular growth during Clomiphene cycles. It allows providers to evaluate whether the follicles are maturing appropriately and to determine the ideal timing for intercourse or intrauterine insemination. Additionally, ultrasound monitoring helps reduce the risk of complications, such as ovarian hyperstimulation syndrome and multiple gestations. Turning to the incorrect answers, option A. Take the medication continuously until pregnancy is confirmed is incorrect because Clomiphene is administered in specific cycles, usually 50 milligrams daily for 5 days, starting between cycle day 3 and 5. Taking it continuously does not improve success and increases the risk of side effects, such as ovarian cysts and endometrial thinning. Option B. Expect potential weight gain due to fluid retention is also incorrect. While injectable fertility medications may cause noticeable fluid retention, Clomiphene is less likely to produce this effect. Common side effects include hot flashes, bloating, visual disturbances, and ovarian enlargement, but significant weight gain is not typically reported. Option C. Discontinue use. If vaginal bleeding occurs concurrently is misleading because Clomiphene may cause some spotting or cycle irregularities due to its antiestrogenic effects on the endometrium. However, any abnormal bleeding should be evaluated, not automatically cause for stopping the medication. Discontinuation decisions are based on the clinical context and severity of the symptoms. Clinically, therapy is usually limited to a maximum of 6 ovulatory cycles, as extended use offers diminishing returns and raises the risk of adverse outcomes like ovarian cysts. Educate clients to have intercourse every other day, starting on cycle day 10 to maximize the chance of fertilization once the dominant follicle matures. Also assess luteal phase adequacy, as Clomiphene can thin the endometrial lining, and some clients may require progesterone supplementation. Remind clients about the elevated risk of multiple gestations, which is about 5 to 8%, and the importance of early ultrasound if pregnancy occurs. Lastly, teach clients to report symptoms like pelvic pain or bloating promptly, as these may indicate ovarian hyperstimulation syndrome, requiring prompt evaluation and possibly canceling or adjusting the cycle. We're getting closer to mastery. Next is question number 14. A 35-year-old multiparous client who experienced a placental abruption and significant postpartum hemorrhage is started on Carboprost trimethamine. Which finding would most concern the nurse as a contraindication to this medication? Now, here are the options. Option A. Respiratory rate 22 breaths per minute with scattered crackles. Option B, uterine fundus firm at the umbilicus. Option C, baseline blood pressure 120/76 millimeters of mercury. Option D, Glasgow coma. Scale score of 15. The correct option is option A, which is respiratory rate 22 breaths per minute with scattered crackles. Now, let us understand why this finding signals danger and what makes the other options non-concerning. Carboprost trimethamine is a prostaglandin F2 alpha analog used to treat postpartum hemorrhage by inducing powerful uterine contractions. However, it also stimulates smooth muscle in the respiratory tract and can cause bronchoconstriction. If a client has a respiratory rate that is elevated and scattered crackles on lung auscultation, this raises concern for underlying reactive airway disease such as asthma or developing pulmonary edema. In such cases, carboprost poses a serious risk of bronchospasm or worsening respiratory compromise and is therefore contraindicated. Now, looking at the other responses, option B, uterine fundus firm at the umbilicus, actually indicates good uterine tone. While this may suggest that uterine adenate is not the cause of bleeding, the presence of a firm fundus is not itself a contraindication to carboprost. The decision to use additional uterotonics would depend on continued bleeding and the overall clinical picture. Option C, baseline blood pressure 120/76 millimeters of mercury is entirely within normal limits. Although carboprost can cause a rise in blood pressure due to its vasoconstrictive effects, a stable baseline does not preclude its use. Option D, Glasgow coma. Scale score of 15 reflects full neurological alertness and orientation. Since carboprost does not directly affect the central nervous system in terms of consciousness, a normal Glasgow coma scale score is irrelevant to its contraindications. Clinically, carboprost is administered intramuscularly in doses of 250 micrograms every 15 to 90 minutes, up to a total of 2 milligrams. After each dose, it is critical to assess respiratory status, especially in clients with a history or symptoms of asthma. If mild respiratory symptoms exist, but use is still being considered, pre-treatment with a short-acting beta-2 agonist like albuterol may help. Though severe asthma remains an absolute contraindication, be alert for side effects such as fever, chills, nausea, vomiting, diarrhea, and hypertension. Keep antipyretics and antiemetics readily available to manage these symptoms. Carboprost is often considered when first-line agents like oxytocin or methylorgonavine are ineffective or cannot be used. Maintain large-bore intravenous access for the administration of fluids or blood products, especially if prostaglandin effects or ongoing hemorrhage lead to hypotension or cardiac instability. Let us wrap up this set of critical reproductive pharmacology questions with question number 15. A 29-year-old client at 7 weeks of gestation requests medical abortion. The provider prescribes mifepristone followed by misoprostol. Which mechanism explains how mifepristone facilitates termination of pregnancy? Now, consider the following options. Option A, directly stimulates uterine contractions to expel the gestational sac. Option B, promotes endometrial proliferation to destabilize implantation. Option C, blocks progesterone receptors in the decidua and myometrium. Option D, inhibits cyclooxygenase 2 to reduce prostaglandin synthesis. The correct option is option C, which is blocks progesterone receptors in the decidua and myometrium. Next, we will clarify why this point is indispensable and reveal why the other responses are not correct. Mifepristone is a progesterone receptor antagonist that disrupts the hormone's critical role in maintaining the endometrial lining during early pregnancy. By blocking progesterone at the level of the decidua and myometrium, mifepristone causes the endometrium to break down and the trophoblastic tissue to detach from the uterine wall. This detachment triggers a drop in human chorionic gonadotropin and progesterone levels and also increases the uterus's sensitivity to prostaglandins. This is why misoprostol, which is administered 24 to 48 hours later, is so effective. It works on a uterus that has already been primed to contract. Now, let us look at the other options. Option A directly stimulates uterine contractions to expel the gestational sac is incorrect, because that is the role of misoprostol, a prostaglandin E1 analog, not mifepristone. Mifepristone sets the stage, but it does not initiate contractions itself. Option B promotes endometrial proliferation to destabilize implantation is incorrect, because progesterone, not mifepristone, promotes endometrial proliferation. Mifepristone blocks this action, causing the lining to become unstable and unsuitable for continued implantation. Option D inhibits cyclooxygenase 2 to reduce prostaglandin synthesis is also incorrect. In fact, that action would do the opposite of what is needed. Non-steroidal anti-inflammatory drugs that inhibit cyclooxygenase would reduce uterine contractility, not enhance it. Mifepristone's mechanism is unrelated to cyclooxygenase inhibition. Clinically, the standard medical abortion regimen begins with 200 milligrams of mifepristone given orally, followed by 800 micrograms of misoprostol administered buccally or vaginally after 24 to 48 hours. Clients should be counseled to expect cramping, heavy bleeding, nausea, and sometimes diarrhea. It is crucial they understand when to seek emergency care. For instance, if they soak through more than 2 sanitary pads per hour for 2 consecutive hours. Always confirm an intrauterine pregnancy before starting this regimen, as mifepristone is not effective and is unsafe in cases of ectopic pregnancy. Also, rhesus-negative clients should receive Rho-D immune globulin afterward to prevent sensitization. Finally, schedule a follow-up appointment or serum human chorionic gonadotropin testing within 7 to 14 days to confirm complete uterine evacuation and to rule out retained products of conception. This completes our comprehensive session on reproductive and maternity pharmacology, packed with exam-focused NCLEX questions and clear clinical explanations. We will be back soon with another essential topic, so make sure you keep tuning in. We bring you new, high-yield NCLEX videos every single day, covering exactly what you need to pass the exam with confidence. If you found value in today's session, be sure to follow us and come back daily, because the next topic we cover might be exactly what shows up on your test. Keep pushing forward, and we will see you in the next video.